Good morning. Welcome and thank you for joining us for our Northern Light Health Good Health is Good Business Zoom conference. We will start off today with an update on COVID-19, followed by an in-depth discussion on youth substance use and addiction. Unfortunately, this is a very important and timely social issue. We'll look at the impact of substance use on the developing brain. We'll lay out the science of addiction, discuss the significance of adverse childhood experiences, take a look at Maine-specific data, and delineate preventive strategies. Our panelists today are Dr. Jennifer Blossom, Assistant Professor, Department of Psychology at the University of Maine. Courtney Evans, Clinical Counselor in Addiction Care Services at Northern Light Acadia Hospital. Hillary Starbird, Director of Community Outreach at Northern Light Mayo Hospital and Northern Light C.A. Dean Hospital. Dr. Jim Jarvis, Senior Physician Executive at Northern Light Health and Director of Clinical Education at Northern Light Eastern Maine Medical Center. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Health. I'll be your moderator for the next hour. Before we get started, I will read our legal disclosure. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Dr. Jarvis will start us off with the latest on COVID-19. Jim?
Thank you, Ed. Next slide, please. So the last couple of months, I think I've been giving kind of positive news when it comes to COVID-19, but here we are again, questioning whether or not we are headed into another wave. And this slide just basically says that at the week ending on July 29th, we saw that the top 10 states saw an increase in admissions for COVID-19. Maine was in that category. And really, we have been seeing an increase in community spread of COVID-19 in the state of Maine, as well as in the rest of the United States. And it has resulted in more hospitalizations. And unfortunately, we have seen some deaths as well from COVID-19. Next slide. But is this actually a wave? This is actually data from more recent data that's actually just from a week ago, which showed that actually Maine's hospitalizations decreased. And so I think what we're really seeing here is an ebb and flow of coronavirus infections and hospitalizations. So we go from 1 week where Maine is at the top of the list in hospitalization rate change to the following week where we're in the lower area. And I think actually that next week we may see that we'll be back up to an increase as well. So it's really the fact that this virus is kind of changing. So next slide, please. So we continue to see consistent indicators that there is increased activity in Maine. We've seen an increase in cases and hospitalizations with a need to actually use strategic protection policies. So some of our hospitals have actually gone back to masking in certain areas within the hospital and increased personal protective equipment for their staff. And so you may see as you visit into both hospital facilities and other medical facilities that you're asked to mask again, and that's probably due to some increase in community spread around those particular areas. We've also seen some indicators that there's increased viral elements in wastewater. And if you've been following these webinars for most of this period of time, you've heard me talk about wastewater indicators before. And typically what we see is an increase in viral elements before we start to see an increase in community transmission and hospitalizations. And so that's where we are both here in Maine and around the United States. The good news is that in general, healthy individuals have had mild or no symptoms from their COVID-19 infections. But as I said, it is still a significant cause of death for the elderly and at-risk populations. Most, if not all, the cases in the US now represent variants within the XBB family, but many newer mutations now exist, including EG.5, which has the code name of Eris. I don't know if that's a terrifying name or not, because I'm not sure where it came from. It really came from a blogger who just started to use that code name. But the good news is that while the name nomenclature changed and we no longer have XBB in the title, EG.5 is just another variant within that XBB family. And that's good news because that's a family that's covered in all current vaccines. Really, one of the concerns that we have, though, is the increase in frequency about these newer mutations that are taking hold in our communities. And right now, it's too early to tell how significant that is. But when we talk about EG.5, which is now the dominant strain in the United States, it still only makes up less than 20% of all cases. When we've talked about dominant strains in the past, we've seen that they've become not just dominant in the total number, but become statistically and percentage-wise dominant. If you remember when we switched from beta to delta, we saw a dominant strain go from about 4 or 5% to 70% in just a matter of weeks. We are not seeing that with EG.5 or any of the other variants. Next slide, please. So in the coming months, what are the things that we need to think about? First and foremost is that there is a triple endemic is possible again, meaning that we will see RSV, influenza, and COVID all hitting around the same time. Influenza vaccines are starting to roll out across the state of Maine. Northern Light Health will be providing those by the end of September, early October. COVID vaccines targeting the XBB family, so that family that right now is pretty much making up all of the strains that are out there right now, are expected to be available in late September and October. They will be monovalent vaccines, meaning they will only cover this one particular strain, which is different than what we saw with the last COVID vaccines, which were bivalent, which included the original vaccine plus one against the Omicron family. This is even more targeted because we know that right now this is what we need. There'll also be an RSV vaccine for those individuals who are over age 60, and that's expected to roll out in October or November. And as you can see, unfortunately, these vaccines will not all come at the same time. There's a lot of reasons for that. Some of them are technical in the development of vaccines, but some of them are financial. And that's because there needs to be determination at the federal level about vaccine administration. The COVID vaccines will no longer be covered by the federal supply, meaning that now this will have to be covered by insurance. For some individuals paying out of pocket, the government is working on a way to make that as a low cost as possible. And the RSV vaccine needed to be added to the vaccine requirement or the vaccine rollout program that the federal government has, and that's why it's been delayed. There is also something else that's coming out on the forefront, and that's a monoclonal antibody protection that's for infants against RSV, and that'll come out late this fall or early winter. And there already is some recommendations that infants be given this monoclonal antibody. We've talked about monoclonal antibodies throughout the COVID pandemic. If you remember, that was one of the first things that we had that could help both treat people who were infected with COVID and protect those people who are high risk. Unfortunately, the mutations that the COVID virus had made those monoclonal antibodies no longer effective, but this is an effective one given for infants against RSV. So what does this all mean? We need to continue just doing all those things that we've been talking about. Wash your hands, cover your mouth and nose when coughing and sneezing. Please stay home when you're not feeling well. Consider masking indoors now as we start to see an increase, particularly if you're in a high risk category or if you're in a crowded space. And I have been seeing far more people wearing masks when they have been out shopping or doing gatherings. If you can do gatherings outside, that's the best protection you can have right now. And with that, I'll turn it back over to Ed.
Well, thanks, Jim. I realize you're going to be available for the Q&A section, but I can't help but think we're providing a lot about an alphabet soup here. So we were talking about EG.5 is the latest subvariant. And then we're talking about XBB will be the monovalent family for the vaccine come the fall. Could you just kind of mention the significance of all these subvariants relative to the vaccine? So for instance, I think it's useful to know that EG.5 comes from XBB 0.1, 0.9, 0.1, for instance. So, you know, so it does get very confusing. I really want to walk away with the idea that the vaccine will be targeting appropriately what's out there in the community.
It will. In fact, it actually targets one of the very first XBB variants that that we saw evolving probably about six or 7 months ago. And so we know that it's specific for that. The mutations that we're seeing that is kind of causing this alphabet soup are all very small mutations within this particular family. And so the vaccine really should be a very good coverage for what we're seeing right now. The concern that scientists and epidemiologists have is the frequency that we are seeing some of these new mutations take hold. These are RNA viruses, and as RNA viruses, they are very fragile, and because they're fragile, they mutate often, but most of those mutations never make it in survivability. They just don't matter. In fact, sometimes those mutations are actually detrimental to the virus itself. What's concerning is that we continue to see in this XBB family variants that occur, mutations that occur that do survive. And so far, we've been lucky. They haven't been more infectious, meaning they don't transmit from person to person more than other ones have, and they haven't caused any more severe disease. That's the good news. The bad news is that it's always a possibility that there'll be a mutation that makes it so that that particular strain is more virulent or can survive out in the wild and pass from person to person more effectively and cause more severe disease. So that's really the reason why there's concern about the variants, not the particular variants that are out there right now. They seem to just be all about this causing the same level of disease that we've been seeing now for over a year.
Mm-hmm. Thanks for that clarification, but this is a time to pay attention, not to be ignorant about it.
Absolutely.
Okay. Well, thanks, Jim. Our next speaker is Dr. Blossom, who will speak on adverse childhood experiences. Jennifer?
Hello, everybody. Thank you so much for having me. We can go to the next slide. So importantly, this is quite a brief overview of a pretty complex and nuanced topic in which there has been a substantial literature that has just grown exponentially, especially in the last 2 decades. But quickly, a brief definition to make sure we're all on the same page. So adverse childhood experiences, or ACEs, as they are more commonly referred to, are preventable, serious, or traumatic events that occur during childhood. And a key piece here that I'd love for everybody to keep in mind and a takeaway is the fact that by definition, these are preventable events. What this means is that there is a lot that can be done to totally eradicate or mitigate the potential consequences or exposure to ACEs. And we'll talk about that in a little bit more detail in just a few moments. ACEs historically were conceptualized and researched with an understanding of looking at what has happened during childhood and how does that impact adult physical health. So historically, ACEs were conceptualized to identify predictors of things that happened during childhood that might inform whether somebody is at risk for developing chronic health conditions like high blood pressure, type 2 diabetes, et cetera. And then more recently, what we have learned is that not only do ACEs demonstrate a clear impact on long-term physical health, perhaps more importantly, in terms of intervention, ACEs have a very real impact in the short term on both physical and mental health, and overall increased risk for physical and mental health conditions. Globally, we see, and this is likely an underestimate, but that ACEs account for about 1/3 of worldwide prevalence of mental health disorders. Thinking more locally, there was a recent study that looked at the 50 states in the country. And in our state, our home state, the average adult exposure to ACEs ranges from 7.3 to 35.6%. This is higher than the national average. And perhaps most concerningly for our home state, there is evidence in the research that there's a dose effect of ACEs. So the more frequent or the higher number of ACEs that somebody experiences, the higher, the poorer prognosis in terms of physical and mental health. And in the state of Maine, 18.5% of adults report experiencing 4 or more ACEs, and that is significantly higher than the national average. We can go to the next slide, please. ACEs are comprehensive, and increasingly research is aiming to identify and understand different events that might be best understood through this lens. I'm not going to read this list to you, but as you can see here, there are a number of events. Some of them were traditionally we've understood to be traumatic events. Others increasingly we're understanding of the individual impact for broader community-based events. And importantly, one of the things that we have started to learn are is that there's not only this dose effect, but that there is an impact of the developmental timing. At what age someone experiences one of these events can have a significant impact on the short-term and long-term consequences. What we know about ACEs is that this impacts the brain and body's physical stress system. So chronic and repeated exposure to ACEs can have an ongoing impact that puts somebody's brain and body into survival mode, which is hard to sustain and can cause significant wear and tear, both physically and emotionally. You can go to the next slide, please. So thinking about the short-term impact, and I am a clinical child psychologist, so of course the focus on the youth and families are of primary interest to me. And what we've learned in a recent research is that ACEs, exposure to ACEs do have an immediate short-term impact on youth mental health. Some of this arises to the level of a mental health diagnosis, such as anxiety, depression, or PTSD. We also see more externalizing difficulties like aggression or ADHD. There might also be other disruptions in healthy development and functioning. So emotion regulation becomes more challenging. We see higher risk of sleep problems, which of course we know has significant impact on physical and mental health. There's increased risk of suicide in childhood and adolescence, increased risk of substance use, which we're fortunate to hear a little bit more about just later today. And then in terms of thinking about children's primary responsibilities, exposure to ACEs and the associated consequences that I was just outlining can absolutely have an impact on learning and cognitive function. If somebody is in fight or flight survival mode, it is hard to focus on math. So this can have a very real impact on day-to-day functioning. We can go to the next slide, please. And increasingly, if there is not intervention, identification, or support for youth exposed to ACEs, we do see significant long-term impact. So some of the risks that were shared or some of the consequences that were shared on the last slide are repeated here. So in the absence of intervention, there is higher risk for adult either continued mental health diagnosis or new onset diagnosis. We see increased risks, risky behavior and risk of intimate partner violence. Increasingly, research is starting to look at the intergenerational effect of ACEs. And we know that for children who have parents with ACE exposure, that the higher the number of ACEs a parent has, the higher risk it is that their children will go on to experience ACEs. So again, really thinking about the list of ACEs, thinking about the potential consequences, we really want to be thinking about and understanding this as a public health issue. Whereas historically, this was viewed more as an individual or familial issue, this is really a broader community and public health issue. Next slide, please. So after reviewing some potentially distressing and dismal information about ACEs, I wanted to end on a positive note. And I know for myself and the area of research and work that I do, that I always like to think about, okay, if I know I've identified this as an issue or a problem, now what can I do about it? And the good news is that there's a lot that we can do. There's a lot we can do as individuals. There's a lot we can do as communities, as members of larger community settings, employment settings, et cetera. And I think about this as twofold. For those who have already had exposure to ACEs, having awareness of this and being able to intervene early can still mitigate or eradicate the potential long-term consequence. So even if the ACEs themselves were not preventable, then it may still be possible to prevent the negative long-term outcomes. Specifically for youth, this is we would focus on supporting them in healthy emotional development, being able to recognize and regulate emotions, working to ensure physical and emotional safety in settings where youth frequent, and importantly, taking a strengths-based approach. As a person who has exposure to ACEs, that is only one aspect of themselves and their history. And we are best suited to support those individuals when we can understand the strengths that they are building, that they are bringing to that experience, including individual strengths, familial, community, and cultural strengths. From a prevention lens, again, thinking about the preventable nature, being able to advocate, supporting policies and legislation that directly address some of the primary causes of ACEs. So thinking about policies or legislation that are relevant to child welfare, education, healthcare, juvenile justice, safety. From a specifically within a healthcare landscape, couldn't help but put this here because this is the primary area of interest for me in my research, and I know is a shared value with Northern Light, but the importance of having a collaborative and integrated care teams in medical settings. Having such teams, having such supports in place allows for broader screening assessment and potentially earlier intervention, and that can go a long way towards mitigating potential long-term consequences. Thank you so much.
Well, thanks, Dr. Blossom. You've certainly opened my eyes to the clinically important ACE that we need to understand and respond to. You know, it seems to permeate lots of what we see out there in mental health. So thanks so much for that. You'll join us again at the Q&A section. Next up is Courtney Evans, who will help us understand the science of addiction. Courtney?
Good morning. Thank you so much for having me. Thank you to everyone for being here who's in attendance today. Next slide, please. This image here is from the National Institute on Drug Abuse, and it sets the stage for this portion of the presentation. It shows a typical developing adolescent childhood brain from about age 5 to age 20. In this particular image, neural connections are being strengthened and pruned away over time. And what this is showing is that there's a decrease in gray matter volume as development occurs. And this is the yellow to blue transitions here in the picture. Next slide, please. Much of our brain development occurs between the early years, 0 to 3, 0 to 5 years. Brains are quite flexible, they're very malleable at this stage, and they're rapidly learning and growing. In these first few years, over 1 million new neural connections are formed every single second. We're even developing natural opiates in our brain in infancy, which are responsible for things like motivation, pain management, and an overall mood. Early childhood development's gained through much of that sensory motor process. We touch, we taste, we see, we hear, we use all of our senses. Each task that we're learning is creating new neural pathways each and every time. And every time those are repeated, those pathways become stronger. We remember them, we know them. We learn that red is red, that a cat meow is a cat meow. Our environment and our social experiences help to set the stage here for brain functioning later on in life. As we develop into our prepubescent to teenage years to early adulthood, our brain continues to develop in parts. Initially, it begins with physical activity, motor activity in the cerebellum. It progresses to our emotions in our amygdala, and then with motivation in our nucleus accumbens. The amygdala is shaping and forming at an extremely rapid rate during teenage years. This is why teenagers experience big emotions. They're really, truly big. This area of the brain is growing and developing so fast, it's so hard to process exactly what's happening. So the next time your teen says, I'm crying and I don't know why I'm crying, they're having really big emotions, and that's okay. That area of the brain doesn't form that concrete pathway to the prefrontal cortex where logical, rational thoughts, good sense of judgment, where that area is located. That doesn't happen until our late 20s. And now even some people are saying not until our 30s. Next slide, please. So why do we use substances? Our teenage years are very risky. Teenagers are driven on impulses, instant gratification, rewards, and doing things that make them feel. So people turn to substances to feel better, to improve performance, and for curiosity and exposure, those teenage peer pressure years. At any point in time during that particular development, when substances are introduced to that still growing and shaping brain of ours, the development can become stunted. The natural progression to where those neural pathways connect to the prefrontal cortex, that becomes interrupted once those substances are brought on board. This is why we may see many individuals later on in their adult years struggling with things like emotional regulation. They might have poor planning or poor judgment, or they might be engaging in risky or impulsive behaviors. Think back to possibly their substance use history when you're working with those adults struggling with those sorts of areas. Maybe they had a substance use issue when they were younger during their teenage years. Maybe that emotional regulation component never actually forged a strong neural pathway to the prefrontal cortex where they learned to have good emotional regulation, good coping skills, healthy strategies for moving forward. So an example of introducing a substance during those adolescent years in particular that's of topic of late is vaping. So I'd just like to take a brief moment to kind of discuss how that has an impact on the developing brain. So we've had years of research on how nicotine impacts the brain, so many years of nicotine alone. Vaping is no different. It does house nicotine in those cartridges, and it can pose risks that include permanent lowering of impulse control. It can also harm areas that are necessary for learning and attention. And so this is why programs like the one you're soon going to hear about from Hillary are so important for our youth and our communities. Next slide, please. So there are risk factors to keep in mind, and they can be both environmental and biological. We saw some of these risk factors earlier through review of the adverse childhood experiences, which is why it's such an important topic to continue to talk about moving forward. It's also important to note that both the environment and biology do play an intertwined part in potential for addiction, as well as to include the age, because those teenage years are the most formidable years when substances can be introduced to the developing brain. Next slide, please. So addiction is a repeating cycle. There's 3 stages shown below. They each impact certain areas of the brain with certain reactions. The basal ganglia is important for motivation, for habits, routines, pleasurable activities. The extended amygdala plays a role with withdrawal and that negative affect, motivating a person to use again. The prefrontal cortex is where that rational, logical thought occurs. And we're going to go into each stage just a little bit further in detail to kind of get a feel for how addiction can happen. Next slide, please. So the binge intoxication stage. This stage is when the individual's actively consuming substances. They are rewarded with this behavior with feelings of feeling good. They get euphoria, pleasure, or possibly no feeling at all, feeling numb. That's one reason individuals turn to using, to not feel anything at all. So the very first time someone uses a substance, it leaves an imprint in the brain in that moment, that feeling, that exact level of pleasure, of excitation. They want it, they need it again and again. They're reminded of this and they want it. Each time they use, they're activating that reward center of the brain with a positive experience, even though that judgment area might be lighting up saying not a good idea. The reward center is lighting up even higher with dopamine surges, and it's a good positive experience. The body begins to develop tolerance to the substance where they need more of a substance to achieve that desired effect, and it begins to flood the brain with those feel-good chemicals. Next slide, please. The withdrawal negative affect stage. Within this stage, after you stop use for a period of time, dopamine levels can become low. They can stay low for a period of time as well. And ultimately, the brain starts to begin to depend on that substance for those feel-good chemicals. The individual will no longer be using a substance to get pleasurable euphoric states. They start to not use to get high, but simply just to get by. The brain reward system begins to decrease in this stage, and then the extended amygdala, within there, stress neurotransmitters become activated. So this produces a negative affective state where the substance is no longer available. The brain will eventually restore that natural balance of dopamine levels, but it's going to depend on a variety of factors, like what it was that they were using, how long they were using it, and their own unique biology. So for some, those feelings are so powerful that an individual is likely to continue to use in an effort to self-stabilize that negative affective state or that negative mood. Next slide, please. The preoccupation anticipation stage this is when somebody can go that length of time between using, but it can vary. It could be an hour for somebody who's in the active throes of addiction, or it could be days. Some may only use substances on the weekends, but during this stage, someone begins to experience cravings to use, which is a preoccupation with wanting to use substances again. There begin to be disruptions in their executive functioning in that prefrontal cortex. So this is where we're able to handle tasks, time management, and emotional regulation. Remember, this is the last to develop in our early adulthood developmental stages. Repeated exposure to substances can interrupt that ability to make good choices about whether or not to even continue to use substances or to step away, particularly when we experience triggers. And triggers can be anything to anyone. It can be people, places, things. I have had patients tell me that triggers have been certain smells in their history. So in summary, in this stage, that individual begins to experience events that not only promote an act of like the substance seeking, but also compulsive, impulsive substance seeking. Our youth are neurologically more at risk as their brains are still developing, and those connections that typically would form, those are the critical ones for the emotional regulation, judgment, and decision making. They're not yet fully developed. And so this is important to keep in mind when we learn about things that Hillary is working on in the community. So thank you so much for allowing me this opportunity to speak to you today.
Well, thanks, Courtney. I realize I might be biased being trained as a scientist as well, but I find what you shared just fascinating and helping us to really understand like the behaviors that we've kind of seen in the course of our lives around us, and always having those questions like, why are people doing this or that? It really gives great insight. So thanks for that, Courtney. Our next speaker is Hillary Starbird. Hillary will bring us into the community frontline, giving us a view of how risk factors can be reduced and prevention strategies applied. Hillary?
Hi, everyone. Thank you. Next slide, please. So my department is community outreach. I work at Northern Light Mayo and Northern Light C.A.D. hospitals, which is in Piscataquis County. We have a team of several people who go out and work within our local schools. We work to prevent substance use, tobacco use. We work on empowerment, trying to reduce those risk factors that Dr. Blossom talked about with ACEs. We know that the ACEs scores are very high in Piscataquis County, and so we really work hard to be a protective factor and make school a protective factor. Next slide, please. This slide is just some of my amazing staff that if you're from Piscataquis County, you've probably seen out and about. We do have 3 people who work solely on substance use prevention and youth empowerment. We have someone who works on healthy eating and active living, and she's actually brought how food affects your mood into all of our work. And then we also have someone who works solely on tobacco prevention. As we know, vaping is certainly a hot topic right now. Next slide, please. This is just an overview of the areas that we work in. Again, the tobacco prevention. We do work also with local employers, municipalities, just the general community on trying to strengthen tobacco-related policies to prevent that. But we mainly work in schools with youth to try to reduce the incidence of them starting initiation of tobacco use or vaping. We're seeing a ton of that in the schools, and the schools are reaching out often to say, what can we do? Again, the healthy eating, active living. We work a lot in the childcare centers. We work a lot in the community with our different food banks and just the community as a whole. The substance use prevention aspect, we do actually work across the continuum. So we work on the prevention piece. We also work on referral to treatment, and we also work on harm reduction. So my team goes across the span there, but we do focus in this instance mainly in the schools on preventing substance use. Next slide, please. So I just felt this was really important to add in here, given the things that Dr. Blossom and Courtney have mentioned, that mental health goes hand in hand with other adolescent health risks. And so we know that when we protect the mental health and we build those strong risk those strong protective factors, that we're reducing a lot of the risks that are associated. Next slide, please. This is a data slide from the Maine Integrated Youth Health Survey. This is a survey that is given to all of the students in the county. So all the schools participate in this. This is given every other year. So we're expecting the 2023 data to come out very soon. And this is basically how we gauge our work and how we're making impacts in our community. And so as you'll see, the circled ones with the arrows are actually the data from 2019, where it shows we were 5 points higher than the Maine average for youth feeling sad, helpless, and depressed for more than 2 weeks. So that was a huge red flag, and we really worked hard to try to reduce that number. And although Maine has come up, we're now level with Maine, and so we have reduced our rate by a little over 1%. And so we're really proud of that growth, and it shows that the programs that we're using are working. Next slide, please. I also just wanted to add this slide in. This just shows that the tobacco use, tobacco prevalence of e-vapor products and things of that nature are higher in Piscataquis County than the state average, according to the 2021 survey data, where about 1.5 percentage higher of students answering yes to using a vape. So if you put that in perspective, 33 kids out of 100 are using a vaping device. That's very concerning and something that we're working hard to address. Next slide, please. These are headlines that everyone's seeing all the time. The nation's grappling with youth health, mental health crisis. Parents are in crisis. Kids are under so much pressure because of social media and cell phones. And for me, it comes back to the fact that when we were in school, many of us, I say us generally, we didn't have the ability to be on social media at all hours of the day. We didn't have the ability to have a bully and a drug dealer in our back pocket, essentially. And so all of those aspects that children can access on their phones and devices at all times is adding to a lot of the issues that we're seeing. And so the ACEs factors, all of those things are being exacerbated by all of these extra things that these students are dealing with. Next slide, please. So to address this, we created positive action teams in our schools, and it was started in 2016, so much prior to the pandemic. And we meet every week in each school. Anyone can join, so any student can join. You don't have to have any special skills or abilities. The only thing that we ask is that you are a positive role model in your school and that you're committed to our mission, which is to reduce substance use, to make a more inclusive school environment, to help peers with mental health crises, all of those kinds of things. And so each one of our teams is made up of about 20 to 30 students. On the left-hand side here, you'll see the list of schools that we have positive action teams in currently. We are working to get into the Greenville school. That's been a little bit of a challenge, but we're hoping that we can break through that this coming school year. Next slide. This is a big collage of different events that students have engaged in throughout the years. The one that says inclusive here is actually a photo of some of my positive action team students from the Guilford School District, Piscataquis Community Secondary School, getting ready for their annual team summit. The summit is an event where all of the teams from all of the schools come together and focus on a county-wide issue. So each one of these teams works in their respective schools to reduce substance use, make their school a better place. And then once a year, they come together at this big summit and they brainstorm ideas, they look at data. This year, we were actually fortunate enough to have Gordon Smith, who's the director of opioid response from the state of Maine, come and be our keynote speaker. He thanked these students for all the hard work that they're doing in their communities. So we just have had a lot of really great success with these students. Next slide, please. So addressing youth substance use through increasing protective factors, again, just being the positive presence in the schools, having students focusing on being positive role models, having community support. We have a coalition built of business partners, community leaders, healthcare providers, all these people encouraging this positivity and letting these students know that they matter. We're also implementing social emotional learning in classrooms. We're working on psychological first aid trainings for school staff and community partners so that they're better equipped to handle students who may be having a mental health crisis. Youth training and mentoring so that these students are actually trained in an evidence-based way to help lead their peers in a positive direction when they're in crisis, and continuing the work with the positive action teams in each school. Next slide, please. I'm not going to read through all of these for you. Some of these are actually redundant, but these are just some of the planned activities that we have for 2023 and 2024. One of the ones that I do like to highlight, though, is the internet safety training for parents with the Maine State Police Department. That's something we're going to do again this year. And it goes back to what I was saying earlier about having the devices and just the unlimited access to the outside world. We have hosted the Maine State Police Department to all of our schools to offer parent night where they discussed all of the different apps, how the apps work, things to look for as a parent, what different emojis mean. I learned a ton as a parent. It's really, really crazy and really scary. So when you see those advertised, I encourage all of you to attend them, even if you don't have a child, if you have a grandchild or a community friend. It's just really great to know what some of these apps are capable of. Next slide, please. Again, this is a continuation of that list, just to highlight a couple of things that are important. We have been working a lot on fentanyl education in addition to our regular substance use prevention efforts. We have seen an uptick of fentanyl in Piscataquis County. We've been working hard with the DEA on the One Pill Can Kill campaign to try to reduce use and try to not see initiation of use in young students. As we know, one pill can kill. And so just getting that education out there for parents, getting lock boxes and lock bags distributed, all of those kinds of things are really important. Next slide, please. I put this in here because we often get questions from people outside of the county that want to know how we do this work. How are we funded? How do we get this work to be successful? And I just felt it was important to mention that we have a lot of hospital support. So our leaders at Northern Light Health are very supportive of our youth programming and making this difference in Piscataquis County. We also have a youth positive action, a youth substance use prevention coalition, I'm sorry, that we call PISUP. That's built of the 12 sectors I mentioned earlier. And that is basically where we plan all of the different things. We assess the data, we look at different things that we should do and can do. We have youth involved in the coalition. We're always looking for new members. So if you're interested in this, please join our coalition. We receive a fair amount of grant funds from the state and federal government. We have a lot of community partnerships. We lean a lot on our youth-led positive action teams. And we also advocate for funding. I believe it was Courtney that mentioned the advocacy part is so important, or it might have been Dr. Blossom, I apologize. But it's just really important to advocate for funding, especially in these rural communities where resources are very, very hard to come by. Next slide. This is just a few photos of our advocacy work from this past year. We did go to Washington, D.C. to meet with Senator Collins. We went to the Communities Anti-Drug Coalition of America training and graduated from that. So our coalition is recognized at the federal level for coalition development. That's actually the DEA Administrator Ann Milgram beside me on the right. And then we also hosted Angus King. Next slide. These are just another kind of collage of some different events that we've done with the youth, and it also highlights the importance of the partnerships that we have with our community members, because In addition to all of the great work we're able to do in the schools around substance use and positive action, mental health, and school climate, we also can leverage those partnerships to advertise events such as the Back to School Bash, where we offered free vaccines. So this helped our immunization rates in the community grow. We also were able to go into the schools to offer vaccinations to try to boost those rates and help parents who maybe are working and didn't have time to get to the provider's office. So we leverage those partnerships for other reasons as well. In the top here, where you see that circle of students, they were actually planning a Project Hope Garden through the Yellow Tulip Project for suicide prevention. And students invited their friends and classmates to come if they wanted to plant a bulb. And we got, I would say, probably a quarter of the school who came out and planted a bulb for someone that they loved. And then down below is just a few more photos of different summit events. That one happened to be held in Dexter, the Dexter school. So that was a fun one. Next slide, please. If you're interested in starting a community positive action team, I just want to give you a few tips. A lot of people say they want to do this. So if you do, form a coalition of like-minded individuals. I'm sure there's a lot of people in your community who want to make a difference. You can gain support from organizations, community-based organizations. Maybe your employer wants to support this effort. Talk to your youth. They're the ones who know all the answers. They know much more than I do. They teach me something new every time I meet with them. They are very honest and open about their ideas and their concerns, and they want to make a difference, and they're really excited to do that. Talk to your local schools, try to work with them, see if there's a way that you can meet some of their needs. And then also, I encourage everyone to look at the Maine Integrated Youth Health Survey data for your region and just see if there's an area that you didn't even realize was a big issue. It's great just to educate yourself on the different data points and what these youth are struggling with. And then lastly, if you want to join us, we are always happy to have a guest at our meetings. We meet in all the schools, so about every day of the week, there's somebody in some school. So we'd love to have you join us. Next slide. Thank you.
Thanks, Hillary. I really appreciate all the great work, but equally importantly, all the great ideas that you put out there. That's fantastic. So now we will have all our panelists join on video for questions. And Hillary, while we're getting all set up on that, I have a couple of questions from our audience for you. First up, are you only working in the Dover area schools currently?
We're working in the Piscataquis Community Secondary School, so that's a middle and high school. We work at Milo, so Penquis Valley Middle School and High School, Foxcroft Academy, Setamocha, and then additionally we work at Dexter Regional High School, and we're starting a Dexter Regional or Dexter Community School, so the middle school level this year. Our funding is primarily for Piscataquis County, so it doesn't give me a lot of flexibility to move outside of Piscataquis County, unfortunately. So that is the reason that it's a little bit limited.
Great. Well, thanks for that. Next question for you, Hillary. First off, there's a compliment that they hear about the great work you're doing up there. And the question leads into, are there any services in Penobscot County?
Yeah, so your counterparts in Penobscot County that do a lot of similar work is Bangor Public Health, and I actually see a couple of people on the call today who are from Bangor Public Health. We work very closely with them in the prevention world, and so if you're from Penobscot County, I would totally give them a shout out and see what programs they're working on and how you could be a partner with them.
Great. One more, Hillary. How can a school find out more info about the Positive Action Summit?
So I'm happy to take emails. I'm not sure if my email is listed on this as a presenter, but I'm happy to email anyone about it. It's a big event. It happens in March of every year, and it's where all the schools that I just mentioned come together at a central location. This year happened to be Guilford. The one prior to that was in Dexter. I believe this year's is going to be hosted at Foxcroft Academy. And we do welcome outside people. We are always looking for guest speakers, people to host workshops and sessions. We held a prevention cafe this year, actually. So during lunch, all sorts of prevention partners from all over Maine, out Maine, all those kinds of things came and set up in the library, and while kids were doing their lunch, they could walk through and get some resources. So I'm happy to share any info with anyone that's looking for some.
Well, thanks for that. I do have one more that came in for you while we're on this topic. Why is there no information in the MIYHS on Aroostook County? Is there somewhere that info can be found? I don't know if you know the answer to that one.
I'm not exactly sure. There should be data around Aroostook County schools. I can look into that for you. If you go to the Maine Integrated Youth Health Survey website, you can actually sort that by county, and I'm pretty confident that there is some in there for Aroostook, and you should be able to pull that, although not all schools are mandated to do it, so there is a possibility that the schools in Aroostook County are not doing it. I actually work closely with the schools and always highly encourage them to do that. So I know that all the schools I'm working in are participating in that. But that's also another community level issue you could raise to your schools if they're not participating, that it would be very important for them too.
So perhaps we could put Hillary's email in the chat. That might work. Okay, thanks.
Thank you all.
Okay, Courtney, this question is for you. Do all addictions fundamentally follow the science you describe?
Well, with respect to how it interacts with that reward circuitry, the typical patterns and the cycles that we kind of went over today of developing addiction, yes. However, it is important to note that there are different substances, and each substance responds differently and with different areas of the brain, which produces different effects. So like opioids will attach to opioid receptors, it releases dopamine, but it also causes that feeling of being high. Alcohol will interact with like GABA receptors, glutamate, and that also produces that similar euphoric feeling, but it's also going to kind of like disrupt and delay the motor skills. So it is kind of, it is, yes, with the cycles of with the withdrawal, with the negative affect, and then eventually the urges, cravings, etc. But there are different physiological responses, both within the brain and body-wise, between substances.
So I have another one for you, Courtney. One of our participants said, thanks for a continued reminder that teens are still in brain development. What resources are available for teens with addiction?
There's a lot out there, actually. Much of the stuff that I got is from the National Institute on Drug Abuse, and the website's drugabuse.gov. It's a government issued, sponsored, run. They've got research, they've got publications. They actually have it's a school program for high schoolers, grades 9 through 12. It's a complete curriculum, and they've got interesting, I don't know what to say, handouts on each substance and how it impacts the brain. So it is really, really neat to check out. So I definitely would start there, and all those resources are free, which is even better.
Awesome. Very helpful. Jennifer, this next question is for you. So considering it is almost a historical joke to say, so you're blaming it on your childhood, what can employers do amongst their employees to help raise the awareness of how important ACEs really are?
Yeah, that's a great question. So I think about this, that there's a few different ways to approach this. Again, thinking about the multi-level impact of ACEs. I think awareness and making a setting more comfortable to be able to address, talk about what comes to mind for me as a relatively new transplant to Maine is when I walk around the small towns that I visited in Maine and seeing all of the domestic violence, IPV, public health signage, that goes a long way towards addressing the problem and addressing that this is a community problem. So having signage like that, check-ins of how are you doing, making it an environment in which people have an avenue in which to share if something's going on. Furthermore, I think just on an individual basis, having compassion and being able to validate. So if somebody shares something, being able to say something like that sounds like that must have been really hard for you. Just having that human moment-to-moment connection can really go a long way.
We were talking at an earlier meeting today about bullying, and I couldn't help but think, how much of a role do ACEs play in the lives of those that bully the rest of the people?
Yeah, that's a great question, and it's an interesting one because you may have noticed that bullying counts as an ACE itself, and certainly what we know from the research, and my area is again going to be focused more on the child and adolescent version of this, but we can think about similar behaviors that we see in adulthood. But that it is often the case that there is not a quote unquote victim and bully, that it is often the case that a person who engages in bullying behaviors has also experienced bullying themselves.
Mhm.
So again, having that compassionate understanding, understanding if maybe this was behavior that was modeled to them from others, and then helping them learn other strategies to get their needs met.
Mhm. Hey, while we're still on the topic of ACEs, I'm going to ask you one more question here. When employees tell stories of ACEs, what can an employer do to help?
Yeah, that's a great question. So again, I think my initial response is just being thoughtful in how one reacts. Again, these can be things that are really hard to talk about, and if someone mentions it, the initial response from another person can dictate their willingness or ability to talk about it more in the future, including their own willingness to engage in mental health services. So again, having that initial validation or compassionate response can go a long way. Having available resources, so employee support services or benefits in which somebody might be able to be able to check in with somebody, having mental health services available, all of those things can go a long way towards helping employees who may have had those experiences.
Great, thanks for that. So our time is running short, so I'll ask our panelists to kind of give 30-second responses, if you will. Hillary, a couple questions for you. Kids are very resilient. Help us understand more about kids being in crisis in the US, like the slide that you shared. And is this happening in other countries as well?
That's a great question, Dr. Goki. So we are seeing it more prevalent in the United States, but there's a couple of theories to that. So in the United States, we have done a good job of making talking about mental health an acceptable topic. In other countries, it's still not as acceptable to bring forward your concerns. And so therefore, we're not sure if the data is skewed because of that. But right now, United States is at the highest for youth mental health crisis.
Great. I've follow up on a question related to one pill can kill. So considering adolescents feel immortal, what effective tools have you seen to help them understand that one dose of fentanyl can be fatal?
We have worked with the One Pill Can Kill campaign a lot. All of the students actually received a presentation from our DEA person for Maine and for New England. So that was very helpful. We also have worked a lot with the Alexander Neville Foundation. I'm not sure if anyone is familiar with that, but they have a wonderful documentary that's called Dead on Arrival, and it actually highlights a lot of very unfortunate events that have happened with youth due to fentanyl poisonings. And so I think that seeing that really hits home for the youth because they can see it can happen. And so I encourage people to watch that film, Dead on Arrival, Alexander Neville Foundation. It's really powerful, and it outlines a lot of the things we're seeing in small town America.
Awesome. Thanks for that, Hillary. Courtney, a couple of quick questions for you. So, I know the topic that you walked us through, you could probably do a day-long seminar on, but do you see a genetic component to addictions?
That's funny. I just did a 2-hour one yesterday.
Okay.
Could have kept going. No, I know we touched on like the risk factors from bio and environment, but there have been twin studies and family studies that have examined the topic of genetics playing a larger role in that potential. Scientists have actually estimated, I think it's like 40 to 60% of a person's vulnerability to addiction, and that genetic factors account for that. So that includes like the effects of environment in addition to genetics, and a predisposition looking at the family history as well. So this kind of shines a light on everything that we have talked about today with recognizing and understanding ACEs, as well as early intervention with those community support services that we have in place. And if we don't have them in place, really working to see what we can do to make that happen.
Well, thanks so much for that, Courtney. I'm going to try to squeeze in one really quick one, 25 seconds on this one. If a person is addicted to one substance, are they at higher risk for addiction to other substances?
They actually are. They're at a much higher risk of cross addiction, which is 2 or more addictive behaviors. So this could be an additional addiction to substances, but it could also be things like gambling, gaming, and sex, or compulsory behaviors. It can occur anytime. They could be in recovery from one addiction, but begin to develop another addiction due to a traumatic event or a natural cause or something like that. And it can happen years later after being in recovery for many, many years.
Yeah, thanks for that insight. That's really helpful. I'll point out that there's a lot of great web links in our chat. Feel free to grab onto that. But unfortunately, we have reached the end of our scheduled time. We've included resources for you at the end of this presentation, as well as the chat room I just mentioned. Thank you all for joining us, and thank you to our panelists for such useful information. I hope this hour will help you to successfully manage your business and all the things around you. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on September 14th. Our topic will be suicide prevention and response. This will be another topic that addresses real concerns in our communities and workplaces. I hope you will join us. We will send you the link for this session. We encourage you to share the invitation with your friends and colleagues. By working together to promote good health, we will be promoting good business. Thank you and have a good afternoon.